turn my volume off. How do I turn it back on?
Okay, hi. Let's start that again. Good morning, everyone. My name is Barry Jackson. Thank you all for joining this morning. Can I ask you all just to go on mute on your own Teams system, please? There is if I'd done it differently, I know there's an override where I could mute everybody, but I haven't set it up as that type of meeting and I don't have the option to do that. So if I can ask you all to mute, and then we don't get too much feedback or anything like that. Obviously, by feedback, I mean noise and unintended feedback, if you like. There'll be loads of chances for you to ask any questions as we go through it.
Yeah, please.
Great stuff. Okay, I'll give it a couple of minutes. 9:31 according to mine. Yeah, just give it another minute or so, and then we'll get started. Hopefully you all saw the update I did yesterday, which is fairly brief because I just got back off holiday. But obviously when I was away, they've the NHS England have decided to put back the implementation of the patient online by default system. So it gives us the opportunity to kind of just revamp this, but I thought it was important just to do this anyway this morning, and I'll have a talk about the sort of plans and what we will now do over the next 3 or 4 months leading up to the implementation of it. Okay, I suspect that's perhaps as many people as we're going to get, so let me just have a quick look here. Okay, we've got 30 people. That's fantastic. Thank you all for joining this morning. Let me just put a couple of links into the conversation, which I will refer to once we get going. So I'm sure you've seen this all anyway, but that's the main link to the NHS Digital system accelerating patient access to records. And the only other one I was just going to do was to the web portal that I operate for N3I. It has all the information governance stuff. I'll just say I'll refer to those during the meetings as we go along. So yeah, can I just once again ask everyone to go on mute? I can hear someone furiously typing away there. I don't know who that is, but I don't mind who it is. Sorry, I'm not accusing anyone, but if you could all go on mute, that'd be fantastic. Right, let's get going. So I was intending to put a big presentation together for all this because this horrible thing is going to happen next week and it's going to bring an end to general practice. It was about to hit us all, and then of course it hasn't happened. So let me just say I don't have a big presentation. This isn't going to take too long, but I just want to perhaps use the opportunity to set out what we can do and to set out some of the basics as I understand it so far from the Accelerating Patient Access program. I'd attended a couple of the presentations that NHS Digital did. Hopefully some of you guys did as well, and that was to get a feel for what their plans are and what the big picture is. So if we do that, if we look at the big picture itself, it is clearly to give patients by default access to their medical record. Now, as you know, they've already got that in law, as it were. So patients in law have got the right to make a subject access request to the practice, and they will be given access to their medical record, or more correctly, we should say, to the information that you hold on them, which predominantly will be the medical record itself. There's a couple of exemptions to that, which we'll mention in a moment. But I think where NHS Digital are going with this is that it's been in the contract for some time. It's one of those things that patients often, when they're surveyed, as the NHS do, say that they would like to have this, the ability to be able just to look online at their information. And as I said, clearly the law allows it. So from a big picture perspective, it is going to go ahead. Now, this is, I suppose, probably worth stating that we've seen these big systems come and go in the past, care.data, and various other, the GP data extraction system from just a few months ago. I get the sense that this is different, and the biggest difference, I suspect, and this is just Barry's view on things, is that this is actually being driven by patients anyway. So there isn't a big. Sorry, can someone go? Can everyone go on mute? I'm getting a lot of feedback from someone's. Great, I think that solved it. So, as I was saying, there's not a great pushback from the public on this one, or there's no big clamor across social media about how terrible it is, and the data grab and all that sort of stuff, because this is about individuals, and it's about actually giving them something which I suspect many of them will find useful. Although, having said that, the vast majority probably won't even use it, of course. So I suspect that although there's a pause in the program and it's been rescheduled back to April, I suspect it will go ahead. The pause has been very much around the collective, how should I describe it, clamour from practices for a little bit more time to get used to it, to work through what the implications are and to understand what they need to do. I think it did come on us fairly quick, and the timescales for going live in December were fairly challenging. So we've now got 3 months to work through what the challenges are and to get used to the system, because I say I'm fairly confident that it is going to go ahead anyway. I don't get the sense that it's going to be cancelled, because there's no big articles in the Guardian or anything like that against it. So I think it will go ahead. So what do we need to consider then? It will represent a significant change to the way that you do record management, essentially, to the way that you operate your systems in terms of recording patient data. And the main thing is, as you know, let's go back to subject access requests. So the fundamental point is that in law, patients can have access to their information. At the moment, they would exercise that through a subject access request, although I know that many of you will have implemented already patient access for that cohort who've asked for it, and at the moment it can be done through either the apps that you get from the clinical suppliers. So in my case, my practice uses System One, and I have the System One app on my smartphone that allows you to access my record. But also now, with the huge uptake of the NHS app, you can access your GP record through it. And of course, the huge uptake of the NHS app has been driven largely by the need for people to get COVID passports or COVID pass, wherever they are, which are on the NHS app. So by default, people have been installed and have now got access to it. So people can do the subject access requests, and many of them already have access to their records. The important point I think to make around this is that when the system is switched on, it will be from the switch on day forward. So to some extent, although I'd like us to look at it, and we will discuss it, and I'll go into some of the details over the next few months, it's not affecting historical records. So it's not affecting the records that you already have. It's giving patients access to their record from the day of switch on forward. So you can slightly park the historical records, although I do think there is work that we can do to kind of open them up, because I think it's not really very logical to just do now going forward. Now, I know most of that is probably a resource issue, how going through the old records before you can make them available, but we'll talk a bit more about that in the coming months, I think. So if we're giving patients online access to their records, what we're doing is we're giving them, I mean, it's near real-time access, as I understand it. And again, I'm telling you the stuff that, from my understanding, having attended the presentations and read through the web pages and so on. So that in itself brings a number of challenges. What are the main ones? And these are the sort of things that were being raised over the last few months at the NHS Digital presentations, and you'll have seen some of them and potentially heard of them. So from a governance perspective, from the Data Protection Act perspective, as we know, when patients put in a subject access request, there are two types of information which can be potentially withheld from them. So in law, they've got the ability to have access to their information, but there are two types of data that we can withhold. And that means that when you receive one of these requests, you have to go through the record to see if there's any of that data in there. The two types of data are third-party information, and I think there's a need for a better guidance around this, because if I'm honest, I sometimes have been confused around it. I think there's the need for some clarity around things such as immediate family, who will obviously be mentioned quite frequently in many people's records, as opposed to what I suspect is more relevant around third-party information, which is where, you know, almost a slightly someone slightly further away than the immediate family. So I suspect and I hope that is something that will come through in this period when we're waiting for more clarity on how to actually do patient access to records. A little bit of better guidance on third-party information would be quite useful, I think. The other one is one which slightly concerns me, and those of you who've heard me do these webinars before will possibly be aware of this. I don't want to overstate it, but I do think that it's an area where, how can I put it? Let's be honest, I don't think we always get it right. And this is around the redaction of information that would cause serious harm to the patient. And I've done and I've put the link there to the main web page that I have, the main IG portal. But I'm just going to copy the specific serious harm test guidance document that I did a while back into the meeting chat there. As I say, it's important to understand the serious harm test is very much that. And I was on one of the webinars that I was on, and I was looking at the questions that were coming through from obviously practice managers around the country. And when a number of them, when they were talking about the serious harm test, were making the mistake that I think is quite easy to do, and that's to conflict serious harm with sensitivity. And the serious harm test has no relation to sensitivity. Sensitive information, we almost expect that to be in our record. There will be lots of sensitive information in people's record. The serious harm test, which is the information which can be redacted, is different to that. It's not looking at how sensitive the information is. It's looking at the impact on the individual of simply telling them the information. And it will be, as I'm just having a quick flick through the document here because there's a couple of things. The BMA guidance says the circumstances in which information will be withheld on the grounds of serious harm are extremely rare. I wouldn't expect practices to do this more than once or twice a year, I would have thought, because you need to understand what the serious harm test is and how it's implemented. There are very few, if any, physical issues that would be affected by the serious harm test by simply telling someone what they've got. It would make their condition actually deteriorate. So in most cases, we're talking about mental health. And in terms of mental health, we're talking about individuals who are at a fairly extreme or at the quite serious edge of mental health, where simply telling them that they may have something that an untreatable condition related to their mental health would potentially cause them to potentially go and self-harm or even at the extreme end commit suicide. That's the level of serious harm that we're talking about here. The bar is very high on it. It's not sensitive information. It's not information that may be embarrassing. It's not information that you wish had been perhaps written differently and that type of stuff. It really is that seriousness that would actually cause serious harm to the physical or mental health of the individual. And it's not that, yeah, it's actually causing the individual to have serious harm done to them by simply telling them the information. So please have a read of that. As I say, I do think that I don't just mean I think from the webinar and the questions that were being asked there, I think this is quite a common thing that people overestimate the impact of the serious harm test. It's very rare that you would have cases that would involve it where it would actually be engaged. So just do that, or do that now and start having a look at your subject access processes already, and just have a look at the number of times in which you're redacting information based on serious harm, and then have a real look at those and see essentially, are you getting it right? Are you getting that test as good as it should be? Because it should be a very, very unusual and rare occurrence, as the guidance from the BMA says. Okay, so having said you've got the third party and the serious harm test information that could be redacted, so you get a subject access request, you work through the record, and you redact the appropriate information. What we're saying now, with patients having default real-time access to their record, you've essentially got to be doing that redaction of those 2 bits of information in real time. So when you have an episode of care that involves recording information about it, you've got to be aware that pretty much after say a consultation, the patient is going to go home and have access to that information that's been put onto their record. So these tests will have to be done, as I said, in real time alongside the patient having access to it, which is the bit that's going to be cause difficulties, I suspect, and I'm sure many of you are already visualizing that now. I don't want to get into too much of the detail of kind of how we're going to do this, because this is the stuff that we're very much waiting for the guidance to come through and tell us, and hopefully help us and give us some guidance on how we do this. But this is just my kind of overview on the system and where it's going to work and how it's going to work. As we said, the one thing we know is that from April, for TPP, System 1, obviously, and for EMIS as well, they're the 2 main systems. They will be switched on. Well, they're the only 2 systems that we have across our area, so it'll affect all practices. And say it's not, I suspect, a discussion about whether it's going to happen or not. And I don't want this group to be doing a discussion. It's not my role to be trying to decide whether it happens or not. You have routes. If you really object to it happening, I suspect you could go through the LMC or BMA or another route. I'm not in that place. My role is to help and guide you through what's coming, and my assessment is that this is going to be coming down the road. We were getting ready for it. We've got to pause, and we need to use that time to work through the problem. So let's say that the first thing we're going to do is we're going to raise all the problems, and I'm more than happy to listen to that. So if you want to drop me a line with what you think are going to cause you the biggest problems around this, then please do that. I will then take those away. I'll work through the guidance that's on the website. I'll listen to the webinars. If you can get to the NHS Digital webinars, great. I will certainly get to all of them, and then kind of hopefully filter that back to you guys around the issues that you've raised. I also have another route, which I'd already raised, and obviously a number of other people as well, which is that there is a National Information Governance Forum that NHS England host. It's a separate department totally to the one that's doing the patient access, and they are now engaged in looking at it and hopefully getting guidance and helping us out on how we're going to do it and picking up the issues that many people have already raised. So, as I say, a lot of the obvious issues will have been raised, I suspect. If there are anything that you think you'd like to put in there, please drop me a line. As I say, I'll kind of turn them around into becoming FAQs, and I'm sure we'll have a number of those. We should also be seeing them on the NHS Digital sites as well, although I know they haven't put them up there yet. I think that was their intention to turn a lot of the questions that they'd had into an answering system. Okay, so yeah, if anyone wants to put anything in now, I'm more than happy, or if anyone wants to come off mute and ask me a question. I think that's probably about as much as I wanted to go through this morning. As I said, I wanted to keep it brief. I just thought it was useful to keep having this meeting anyway. It hasn't gone away. 3 months will very quickly be back upon us. So if anyone has got any queries, Fiona, how is this going? Yeah, as I understand it, letters will be included in what patients can see. If there's an error, then they will see, if a patient gets a letter gets scanned onto the wrong record, then essentially the wrong patient will see that letter. We have to some extent, what should I say, cross our fingers. We have to hope that patients would, in that scenario, that a patient would do the right thing essentially and tell the practice if they note an error. And actually that may be something, and I don't know how relevant this is, but I know NHS Digital made a point around it on one of the webinars, that actually this could be a a force for good in terms of data quality. So if in the situation there where there's an error scanning a letter, the letter gets put onto the wrong patient record, how would you know that error had happened? Actually, it may well be that by patients looking and saying, hang on, that's not me, there's been an error here, they will pick up errors as well. It's someone else looking at the record. Clearly, they're looking at their own record, so they could potentially pick up errors and highlight back to you. As I said, we just have to hope that they would do the right thing. You can't enforce a level of confidentiality on an individual if that patient decides to go to the press or whatever, then that's what they do. We would just hope that if they detect an error like that, then they would do the right thing and go back to the practice and inform you guys. My understanding, Ruth, is that patients will see everything that's on the journal of communications. I'm not quite sure how it will look, but there's nothing that they won't see. Essentially, they'll see a full the full record. What I would say to you all as well, and I'm always quite surprised within my department, I mentioned the other day, if someone got the NHS app and virtually no one had it. If you don't already have the NHS app, I would suggest you put it onto your smartphone and have a look at it. If you don't want to or can't do that, then perhaps ask one of your members of staff who are willing to kind of give you a look at it so you know what it looks like, because I think that's going to be quite important to see what patients are seeing. And of course, we're all patients anyway, so you can all look at your own record and see what it looks like and see how this is going to work from both angles, if you like. Yeah, Caroline, that's a really good question, and I know that's one of the most significant ones that came up. So things such as test results, and Caroline saying letters being put on record potentially before the patients had the opportunity to be told face to face. That obviously there are some results and some things that you'd want to sit and talk through with the patient rather than them just seeing on a on their app when the test result comes through. So I think that is clearly something which the system is going to take into account. Now, as I understand it, and obviously you guys know this way better than me anyway, as test results come through, they don't necessarily go directly into the record straight away. There's a pause, they have to be checked, and potentially you could call the patient forward to explain to them. So that's something that you may need to kind of strengthen, if you like, the process for doing that, for ensuring that these test results are checked prior to them going onto the patient record. This is going to be one of those things that, as I say, is going to be a kind of side consequence of what they're doing, but patients having that real-time access, we may have to look at the processes around getting test results back from a hospital. MDT letters, yeah, any type of information really that the patient potentially isn't already aware of, we're going to have some process by which it's looked at. Is it appropriate for it to be put onto the record where potentially the patient can see it, or is it one of those things where you actually, what you need to do is call the patient in and have a meeting, or at least perhaps a phone conversation with them, and explain what the information is, whether it be a test result or whether it be a letter, before it gets put onto the record. And they're really good points, and they are points that I know were raised with NHS Digital, and I think from a healthcare perspective that they are very, very important, and we need to get something in place to deal with this, to deal with the situation, whether that be local processes or whether System 1 and EMIS can change, whether they can be adapted to fit in with this. It's not entirely clear how they're going to be changed. Obviously, at the moment, as I understand it, if a patient wants online access, you have to go in and grant it. This is now going to become, by default, patients will have online access. You will have the ability to switch it off, and that leads us into another difficult area around people in coercive relationships, which has been raised as an issue. Of course, to some extent that's already an issue anyway, because people can ask to see or to have this turned on, patient access now, and you don't. It's quite right that you don't know the impact that could have on a relationship, and partners wanting to see things and that type of stuff. Again, I think we'll just have to wait for the guidance on that, but that is a significant issue, I think, that the people are aware of. I know it was discussed on one of the calls that I was on. Okay, I think that's probably more than half an hour or so. So I just thought it was useful to keep this going now. We'll need to keep the momentum on this going and possibly have a webinar every month over the next sort of 3 months leading up to April, which we can just sort of update things. You can discuss it. Certainly it's something that needs to be discussed in the practice with others, with your GPs and other clinical staff, and of course the administration staff who will be doing some of the work as well. So it's a topic that I think you need to be discussing and raising issues and raising questions and putting them back, and certainly putting back through me. And if I can get an answer, I'll do that. But as I say, I suspect it'll be a case of forwarding the questions on and seeing how NHS Digital are looking at it. Jaya, I'll make the webinar available. I'll put it onto the web portal. So on the web portal, there's a video section. I'll add this morning's webinar onto there. Okay, and on that note, a final plug for the web portal. Please keep having a look at it. I try to update it usually every week or so. The section that says IG News, I think along the top, are just little things. So once a week, I kind of look through my emails and say, okay, is there anything in here that people might find of interest? And I pick out little points and various bits of probably, well, I would say quite useless information. But there's so there's a document of medical examiners coming in. I'm just having a quick click through this. Claims for damage or distress. That was a good news story where you often hear people say, I'm going to sue you for losing this information and so on. And actually, there's a very good legal case there where the judge has set a precedent saying a claim for damage or distress under the Data Protection Act has to be really quite severe, and just losing someone's information isn't enough. Some work I'm doing on physical security with the LMC. You should be seeing something around that fairly soon. Anyway, that's all. That's just me having a quick flick through there. Yeah, just to plug that website again. Right, I think that'll do. Please email me in anything that you think about. Obviously, and there are other routes as well. Of course, go direct to NHS Digital if you like. But I'm more than happy if you send stuff to me. I'll kind of collate them all together and put them to NHS Digital. And I'm hoping that over the next few months, we'll see some clearer guidance about how this is going to work. I think the pause in it, putting it off for 3 months, is a good thing. I think it gives us the chance to think it through, if you like, if nothing else at all, to have at least thought about it. I think starting at the beginning of December with the short notice that we had was a bit, was always going to be a bit rushed. So we've got a couple of months now to talk through the issues that are going to be out there, and see what we can do, and hopefully we'll be in a better position than we were going to be if it had just come in December. Yeah, today. I think the 3 months will be, or presumably what that's for, to give people the opportunity to look at the changes they may need to make in their day-to-day sort of work in the processes that go on in the practice, and yeah, as I say, have the opportunity to look at the different changes you may need to make. So as a PT on 12th of January, yeah, I'm more than happy as always to come and talk to any group, anything like that. And you guys all know I am. Drop me an email, give me a call if you want to, if there's anything specific. And like I say, I'll do these every 3 months. So as we lead up to April, and we hear anything more, I'll keep doing these and summarize the stuff that's coming out for you. Okay, I'll call it a day. Someone's asked for a link to the portal, so I'll just put the web portal link back up on there again, for those of you who missed it earlier. And now, I said this webinar I've just done is recorded, and I'll get that put onto the web portal as well. Okay, thanks very much, guys. We'll call it a morning. Thank you all.
Thank you.
Thank you. Thank you, Barry.